السلام عليكم شباب. اليوم محاضرتنا تتعلق بموضوع خاص الجراحة بالأورال ميديسين هو orofacial pain and its management. أخي البين من المواضيع المعقد اللي ترتبط بالدينتال. أول شيء نعرف البين. Definition of pain. The International Association for a Study of Pain عرفت البين هي pain is an unpleasant sensory and emotional experience associated with acute, actual or potential tissue damage or described in terms of such damage. The manhaj عرف an unpleasant emotional experience usually initiated by noxious stimulus and transmitted over a specialized neural network to the central nervous system, where it is interrupted as such. The incidence of pain, pain very huge amount in population. According to Cohen, it was found that 21.8% of adults in the United States experience of orofacial pain symptom within 6 months of study. The most common pain was toothache, which was estimated to have occurred in 12.3% of the population. How classification of pain? Classification of pain قسمين إلى قسمين. Somatic visceral. Somatic mean the somatic that either superficial from skin and subcutaneous tissue, example superficial cut, burn, and etc., or deep from muscle, bone, fascia, periosteum, like fracture, arthritis, fibrosis, rupture of the muscle of the leg. هاي somatic. أما visceral from viscera, example angina pectoris, peptic ulcer, intestinal colic, renal colic, and etc. Other classification قسمها إلى typical pain disorder, atypical pain disorder. Typical pain disorder like periodontology, neuralgia, trigeminal neuralgia, visceral migraine, cluster headache, otic like otitis media, sinus like sinusitis, heart cardiogenic jaw pain, cerebral gland disorder, musculoskeletal disorder. أما typical causalgia, reflex symptomatic dystrophy, atypical facial pain, phantom tooth pain, neuralgia, including the cavational osteonecrosis. What's the factor affecting pain? many factors. حقيقة راح أعددها بصورة سريعة لأنه طويلة. فنقول estimate emotional stage like the pain threshold depend greatly on the attitude toward the procedure. In case of emotional unstable and anxiety patient, the pain threshold is low but reaction is high. Fatigue, like pain reaction threshold is high in subject who has good night's sleep and relaxed than those person who are tired. In age, older individuals tend to tolerate pain and thus have higher pain reaction. In racial and national characteristics, it has been said that racial characteristics are reflected in the pain. In sex, men have higher pain threshold than women. In fear and apprehension, most cases pain threshold is lowered as fear and apprehension increase. What mean referred pain? Referred pain is occurring in a visceral structure is usually not felt in the viscous itself but on the surface of body or in some other somatic structure. They may be located quite some distance away. Such type of pain is said to be referred pain. Anatomic consideration. We must know the anatomic consideration of the innervation that supply the head and neck, and according to that we discuss the pain. We have the first trigeminal nerve and its branch, the ophthalmic branch, maxillary branch, and mandibular branch. There are facial nerve and small root of it have sensory for the auricle inside the auricle, and the external acoustic meatus, cervical nerve 2, cervical nerve 3, that supply the angle of the mandible, glossopharyngeal nerve that supply the posterior third of the tongue, and the vagus nerve that supply the neck. The categories of facial pain. We have local pain and like dental pulpitis, dentin hypersensitivity, apical, periodontitis, cracked tooth syndrome. Gingival, like primary hyperpatic gingivostomatitis. Muscular, like ulceration, mucosal. Cerebral gland, like acute separative adenitis. Temporal mandibular joint, and maxillary sinus, like sinusitis and malignancy, that lead to local pain. Neurological pain, like trigeminal neuralgia, glossopharyngeal neuralgia, Ramsay-Hunt syndrome, post-herpetic neuralgia. Vascular pain, like giant cell arthritis and variants, migraine and variants, cluster headache, chronic paroxysmal hemicrania. Psychogenic pain, like atypical facial pain, atypical odoralgia, burning mouth syndrome. Referred pain, like cardiac pain. What you must consider in history and examination of the patient having pain. What are items that history should focus on it? When investigation acute dental pain, the history should focus on the pain, location, type, frequency and duration, onset, exacerbation and remission, for example, the response to heat or cold, severity, area of radiation, current medication, history of allergy. Associated pathology and referred pain should also be considered. Current medication. Information regarding patient medication not only provides insight regarding medical status, but also may alert the dentist to possible drug interaction. Careful attention should be paid to any prescribed medication the patient is taking currently or has taken within the false mouth. History of allergy. The patient may label an adverse drug experience as an allergic reaction. Any report of allergy should be further questioned to clarify that signs and symptoms were consistent with hypersensitivity reaction, rash, pruritus, urticaria, airway compromise. What are structures that need to be examined? The following structures need to be examined carefully in order to ensure that the pain is in dental origin. You must examine the tongue, buccal mucosa, flora of mouth, hard palate, teeth, and periodontal tissue, tonsil, temporomandibular joint, the airway, ears, cerebral gland, and lymph node. You must examine all if there are. Which tests can assist in diagnosis of? There are several simple tests that may assist in diagnosis of dental pain. Pulp sensitivity test, dry ice, or an ordinary ice stick made in a plastic or glass tube is placed on the cervical third neck region of the tooth crown. A response to stimulus indicates that the pulp tissue is capable of transmitting nerve impulse. No response may indicate pulp necrotic. There are several simple tests that may be assist in diagnosis of dental pain. Percussion test, usually an instrument handle, the tooth is tapped in the longitudinal axis. A painful response suggests possible periapical inflammation. Propping, placing a fine plant propel gently onto gingival sulcus surrounding the tooth enable the health of gingival tissue to be assessed. Bleeding and or sulcus depth greater than 3 to 4 mm indicate gingival disease. Mobility test, handling tooth firmly on the buccal cheek and lingual side between the finger enable the mobility to assess. All teeth have small amount of mobility, less than 0.5 mm, but visible movement suggests loss of bone support around the root of the tooth. Palpitation. Careful palpitation around the area of concern may reveal tenderness and the type of extent of swelling. Radiographic examination. If it's possible to obtain a screening radiograph such as an orthopanography (OPG), this may assist in diagnosis and location of the cause of pain. The radiograph should show clearly the apical and periapical structure of teeth and associated tissue. The relationship of maxillary molar and premolar to the floor of maxillary sinus can be examined, and the radiograph may reveal recurrent caries or periapical radiolucencies associated with established infection. There are several simple tests that may assist in diagnosis of dental pain, like radiographic examination. In this figure, we can see the roots of the tooth, and there are periapical lesions as radiolucent. Now we consider on dental pain. The dental pain, the hydrodynamic theory of dental pain has strong experimental support and postulates that movement of fluid through the dental tubule result in pain. Stimuli including air, fast, cold, and hypertonic sugar, sweet, can produce dental tubule fluid movement. Movement of this fluid results in stimulation of nociceptive nerve fiber located on pulp tissue side of the dental tubule. Type of dental pain. Common type of orofacial pain likely to cause patient to seek emergency care at categories in this figure. The character of pain can point to diagnosis. If is the pain is short, sharp shutting or dull throbbing pain. Sharp, short shutting either triggered by hot, cold, sweet, like exposed dental from gingival incision, lost filling caries, or triggered by biting, crack, cusp, lost filling, fractured tooth. Among dull throbbing persistent, like localized tooth tender to percussion, apical infection, sinusitis, or like local inflammation, impacted pericoronitis, or other two types, generalized inflammatory and necrotic, like acute necrotic ulcerative gingivitis, localized diffuse pain, dry socket, temporomandibular joint disorder. We start with short-shotting acute pain. This type of pain can be generalized or confined to one region of the mouth. After exposure of dentine, either by loss of enamel or by loss of cementum and gingiva, dentinal sensitivity can develop. Dentinal sensitivity is characterized as sharp pain that occurs soon after provoking stimuli. The pain may be due to fluid movement through the tubule in the dentine, or there may be some initial inflammatory change in the dentinal tubule valve. It can be caused by caries, dentinal exposure on root surface, split cups, loss or fractured restoration or fractured tooth. Acute pain typically results from an injuries insult and is self-limiting. The report of pain typically stops before the prescription injury heals completely. Strategy for acute pain management are based on knowledge of peripheral and central mechanism of nociception. In general, acute pain management may involve a three-pronged approach: inhibition of biochemical process signaling tissue injury, blockage of nociceptive pulse along the peripheral nerve, and activation of endogenous analgesic mechanism in central nervous system. This approach can be employed simultaneously to result in acute analgesia. Patients complain commonly of sharp pain associated with hot, cold, or sweat stimuli. The pain is only present when a stimuli is applied. In the case of cracked cup, graining bread or hard food may create sharp pain that may be spasmodic or biting or chewing. This leads to short, sharp shotting pain. The short, sharp shutting pain, again with the gingival recession, recent scaling or tooth wear due to high acid diet or gastric reflux. There may be a generalized dentine sensitivity over with caries, fractured filling, and cracked cusp. The pain tend to be localized to the affected tooth. The intermittent sharp shutting pain and also symptomatic of trigeminal neuralgia, so care must be taken not to mistakenly label tooth ache as neuralgia. The treatment of short, sharp shutting pain. For root sensitivity, the use of descending toothpaste and reduction in acid and diet will help resolve the symptom. Use fluoride mouth rinse may also help. In the case of caries or lost offering or fractured tooth, coverage of the exposure dentin with a temporary restoration with eugenol will relieve the symptom. Traditional pharmacological pain management usually involves the administration of opioid analgesia. Parenteral opioid analgesia are the standard of care for severe pain in hospitalized patients. Oral form or administration in dental clinics. Unfortunately, the oral efficiency of most opioid drugs is very poor, and additional problem with opioid relates to their propensity for nausea in ambulatory patients. Since the most dentinal pain situation involve ambulatory outpatient requiring oral analgesia, the usefulness of opioid is limited to adjunctive rule. In general, the combination of aspirin-like drug with opioid increase analgesia at the cost of increased incidence of side effects. Dull, throbbing, persistent chronic pain. This type of pain may have several causes. This includes tooth problem, food impaction, pericoronitis, acute necrotising, ulcerative gingivitis, temporomandibular joint disorder, or even maxillary sinusitis. Painful tooth problem. The most common dental cause of dull, throbbing, persistent pain is caries. In many cases, this is recurrent and associated with an exacting restoration. Where the pulp is affected irreversibly, necrotic may also follow with possible development of periapical infection. A fractured cusp involving the pulp or a large deep restoration may also be associated with this type of pain. Affected teeth may be tender to percussion and later stage of periapical inflammation. There is considerable variation in the pain reported by patients, but it commonly starts as sharp tapping pain that becomes progressively dull and throbbing. At first, the pain may be caused by stimulus, but it then becomes spontaneous and remains for a considerable time after removal of the stimuli. The pain may be palliated and referred to other area of mouth. This type of pain tends to cause a patient to have difficulty sleeping and may be exacerbated by lying down. Heat may make the pain worse, whereas cold may alleviate it. The pain may be intermittent with not regular pattern and may have occurred over months or years. If there is periapical infection persists, patient may no longer complain of pain in response to thermal stimuli, but rather of sensitive on biting. Treatment of dull, throbbing, persistent pain. Treatment of affected teeth will involve either root canal therapy or tooth removal. In some patients, apical inflammatory can lead to cellulitis of focus characterized by rapid spread of bacteria and their breakdown products into surrounding tissue, causing extension, edema, and pain. If system signs of infection are persist, for example, fever and malaise, as well as swelling and possible trismus, limitation of mouth opening, this is surgical emergency. If pus is present, if need to be drained, the cause eliminated and host defense augmented with antibiotics. The microbial spectrum is mainly gram-positive, include anaerobes. Appropriate antibiotic would include penicillin or first-generation cephalosporin combined with metronidazole in more severe cases. Do you think that other drug is needed? When approach with some clinical support is the use of antihistamine as adjunctive analgesic agent. Histamine is released during mast cell degranulation. Generalizing from animal study, the antihistamine should demonstrate greater efficiency when given before surgery, but this has yet to be established in the clinic. Several clinical studies have demonstrated that antihistamine serve as effective adjunctive analgesia in oral surgery model, though in case of chronic pain, non-steroidal anti-inflammatory drug combined with antihistamine give good results. Food impaction and pericoronitis. Soft tissue problem that may cause dull, throbbing, persistent pain, including local inflammation, acute gingivitis associated food impaction, or pericoronitis. Chronic periodontitis with a gradual bone loss rarely causes pain, and the patient may be unaware of the disorder until tooth mobile is evident. There is quite often bleeding from the gum, gingiva, and sometimes an unpleasant taste. This is usually generalized condition, however, deep pocket with extreme bone loss can occur around isolated teeth. Food impaction in this area can cause localized gingival pain. Poor contact between adjacent teeth and the presence of an occluding cusp forcing food into this gap can also cause build-up of food debris and result in gingival inflammation. Acute pericoronitis involves bacterial infection around an erupted or partially erupted tooth and usually affect the lower third molar wisdom teeth. The condition is often aggravated by the upper molar impaction on the swelling flap of the soft tissue covering the unerupted tooth. There may be trismus. Treatment of food impaction and pericoronitis. Food debris should be removed and drainage established if pus persists. Irrigation with chlorhexidine and rinsing the mouth with root hot salty water is recommended. Early referral to dentist to indicated cellulitis can develop, requiring urgent referral to a surgeon. Acute necrotizing ulcerative gingivitis. In acute necrotizing ulcerative gingivitis is rapidly progressive infection of the gingival tissue that causes ulceration of the interdental gingival papillae. It can lead to extensive destruction. Usually young to medial-aged people with reduced resistance to infection are affected. Men are more likely to be affected than female, with stress, smoking, and poor oral hygiene being a predisposing factor. Halitosis, spontaneous gingival bleeding, and punch-out appearance of the interdental papillae are impaired signs. The patient quite often complains of severe gingival tenderness with pain or an eating tooth brushing. The pain is dull, deep-seated, and constant. The gum can bleed spontaneously, and there is also an unpleasant taste in mouth. Treatment of acute ulcerative gingival stomatitis. As there is an acute infection with mainly an anaerobic bacterial treatment follows surgical principle and includes superficial debridement, use of chlorhexidine mouthwash, and course of metronidazole tablet. Treating the contributing factor should prevent a recurrence. Dry socket. One of the important after extraction of teeth is complication. Adult throbbing pain developed 2 or 4 days after mandibular tooth extraction, if rarely occur in maxilla. Smoking is a major predisposing factor as it reduces the blood supply. The tissue around the socket is very tender and with a necrotic bone is exposed in socket. Halitosis is very common. Treatment of dry socket. The area should be irrigated thoroughly with a warm saline solution. If loosened bone is present, local anesthetic may be necessary to allow through cleaning of the socket. Patients should be shown how to irrigate the area and told to this regularly. Analgesics are indicated, but pain may persist for several days. Although opinion is divided as whether or not dry socket as an effective condition. We do not recommend that use of antibiotic in its management. Sinusitis. This is caused by infection of maxillary sinus, usually found an upper respiratory tract infection. However, there can be a history of recent tooth extraction leading to an orofacial fistula. Patients usually complain of unilateral dull pain in all posterior upper teeth. All these teeth may be tender or percussion, but they will respond to pulp sensory taste. There are usually no other dental signs. The pain tends to be increased on lying down or bending over. There is often feeling or fullness of the affected side. The pain is usually unilateral, dull, throbbing, and continuous. Quite often the patient feels unwell, generally and finish. Treatment of sinusitis. Pain originated from the sinus arises mainly from pressure. Decongestant can help sinus drainage. Antibiotics properly have only minor role in mild case. Referral to an otolaryngologist for the endoscopic sinus surgery may be indicated in chronic case. Now go to other categories of pain who are trigeminal neuralgia. What means trigeminal neuralgia? Definition of it: usually unilateral severe sudden stopping pain is disturbing of one or more branch of trigeminal nerve. Etiology and pathophysiology. Trigeminal neuralgia divided to primary and secondary symptomatology. The primary trigeminal neuralgia are a result of visceral compression of trigeminal nerve near its entry into bonus, superior cerebral artery. Secondary trigeminal neuralgia causes include multiple sclerosis tumor, basilar artery aneurysm, or ectasia. Clinical feature of trigeminal neuralgia. It is present as episodic, recurrent unilateral facial pain described as sudden high-intensity tapping or electrical-like shock. Lasts for a few seconds to minutes. Pain is frequently triggered by travel stimulation such as touching of face, washing, shaving, chewing, and talking. Trigeminal neuralgia, it occurs mostly after 50 decade, mean over 50 years old. Clinical examination of face is nearly always normal. If sensory loss is present, a mass lesion is more likely in young patients with trigeminal neuralgia. Multiple sclerosis should be considered. Diagnosis of trigeminal neuralgia. Diagnosis depends on history and clinical examination. Careful search for ipsilateral dental pathology should be undertaken. MRI and MRA and performed if there is suspicion of underlying pathology. The trigeminal neuralgia is non-analgesic drug like carbamazepine give excellent result in treatment of trigeminal neuralgia. The dose of carbamazepine 100 mg twice daily. No improvement. The dose is increased to 200 mg per time daily. No improvement. Dose can be augmented until 1,600 mg a day with monitoring of plasmatic concentration of drug should be achieved regularly. If with such dose there is no improvement, then the phenotine is used 150 to 300 mg daily. The other pain, temporomandibular joint pain. Diazepam has both sedative and muscular relaxant effect, so it helps if the origin of the stress psychotic. In other cases, the use of paracetamol 250 mg in combination with fluoxetine muscle relaxant 300 mg is recommended for time daily. Now, other type of pain is atypical facial pain. This consists dull, itching pain, deep, diffuse, variable intensity, and the absence of identifiable organ disease. It's more common in female, most potential middle-aged and elderly. Clinical feature of atypical facial pain. Often difficult for a patient to describe their symptoms. Most frequently described as deep, constant itch or burning. Does not awoke a patient. Does not follow a canonical pattern and may be bilateral. Affect maxilla more than mandible, often initiated or exacerbated by dental treatment. Examination entirely normal, often have other complements such as IBS, dry mouth, and chronic pain syndrome. The use of tricyclic antidepressant look helpful like amitriptyline. Anyway, the prescription of such drug should not be done by a dentist. The therapeutic use of non-opioid analgesia. Optimal analgesia, the therapy for military dental patients should be efficient with a minimum incidence of side effects. Non-steroidal anti-inflammatory drugs are the mainstay of therapy for management of acute dental pain. They have also been evaluated for chronic orofacial pain, for minimizing edema after surgical procedure, and for endodontic pain. Ibuprofen is superior to aspirin, acetaminophen, and a combination of aspirin and or acetaminophen plus codeine 600 mg, but has fewer side effects than an opioid combination. Marked doses of non-steroidal anti-inflammatory drugs are generally equally effective but vary in onset, duration of action, and adverse side effects with repeated dosing. Parenteral ketorolac is comparable to injectable opioid drug but has fewer side effects, especially in ambulatory patients. When managing dental pain, optimize non-opioid agent before adding an opioid to the regimes. Limited affiliation is patient prone to nausea and vomiting. If the patient is opioid dependent, consult with a primary practitioner regarding appropriate diet and dosage. Decrease dose in elderly patients or in those who have renal or hepatic compromise. Combining of non-steroidal with an opioid results in additive analgesia but has increased side effects, especially in ambulatory patients. A full therapeutic dose of each ingredient in the combination is needed for achieve general to therapeutic advantage. Thank you for your listening to this lecture. إن شاء الله سويدته المحاضرة الأخيرة لهذا الكورس. إن شاء الله محاضرة الأخ دكتور مهدي